Hi, everyone. It's such a pleasure to be here. Thank you for having me. I'll go ahead and share my slides. And thank you, Talia, for your very kind introduction. So I'll be talking today about a virtuous cycle and learning about policies that support health, the economy, and equity from COVID-19. And much of this is based on our experience leading the COVID-19 US state policy database on policies to prevent economic hardship and prevent COVID during the joint health and economic crisis. So I'll tell a couple of success stories and a story of how we can do better and speak to the importance of continued research on policies as we think about the longer term future with COVID. So the premise of all of our work, which we actually wrote out in March 2020, is that COVID brings joint health and economic disasters. In a context of structural racism and inequities, disasters make disparities worse. Policy actions during disasters can reduce or exacerbate disparities. And across administrations, federal leadership is key. Only the federal government has the financial, coordinating, and convening capacity to lead a comprehensive response. And federal policy decisions dictate what happens at the state and local level and in institutions. And disasters can be an opportunity to change structural inequities or inform them in the future. So this is why we started the COVID-19 US state policy database. We really designed it to inform rapid response research so we could inform policies that help support people and their health and well-being and reduce disparities in real time in a rapid response kind of way. And the longer term recovery requires that as well. We had some pretty effective responses at the beginning, and now we're in this sort of middle period where we see food insecurity rising again. We see very high rates of COVID. We see high rates of work being disrupted. We see high inflation related to that. There's actually a lot of work to do to understand and inform policies in this period as well, and to better inform us in the next disaster. A lot of what I'll talk about today is that we laid the groundwork for the most effective elements of the COVID response with work that happened in the wake of the Great Recession, that happened after natural disasters like Hurricane Katrina. So I think that this work that we do over the coming decade will be important for informing how can we have the most effective response the next time we have a crisis, or when we have increasing natural disasters because of climate change. Hopefully there's a lot we can learn about how to do the policy work better and more equitably. So this is the context in which the COVID-19 pandemic hit the United States, and it set the stage for so much of what happened afterward. Historical policies like slavery and redlining and modern day policies like a low minimum wage have shaped a context in which Black people have 1/8 the wealth of white people, and Hispanic people have 1/6 the wealth of white people. And this set people up for whether they would lose work during the pandemic, whether they were working and had educational opportunities and jobs that meant that they were in occupations with a lot of exposure, and whether they were forced to go to work in unsafe conditions because they needed to bring home a paycheck. Because with little wealth, it doesn't leave you room to miss a paycheck. And those wealth inequities are what have shaped disparities with disasters and diseases. So after the Great Recession, it took a lot longer for people who were Black and Asian to recover relative to people who were white. And that was partly because of an insufficient policy response during the Great Recession. So again, this is where it's really important. The learning we have from then formed a better response to the COVID crisis. This is why disasters like Hurricane Katrina hit low-income people and Black and Hispanic people the hardest. And this is why we see disparities in the burden of HIV. Infectious diseases that spread exponentially tend to be somewhat exponential in their inequities. That's what we see with COVID too. The COVID-19 pandemic economic crisis was particularly inequitable. So it's these compounding inequities. But people who are in low-income households here in purple, they were hit hardest and longest, where they lost the most employment and they lost it for a lot longer. And this was much worse, much more of a disparity than in prior recessions. So actually, I also really think that data journalism and descriptive data has played a very important role in helping people understand priorities and understand the state of the world during the pandemic. And this is one of those graphics that really helped us shape our work and focused on people in the lowest income households. Those same wealth inequities that we saw at the beginning, that shaped a context in which people had different exposure to COVID-19 at work and in house and due to household crowding. And when we look at age-specific disparities in deaths, so not just age adjusted, but within age groups, the magnitude of the disparities really becomes apparent. This is just through January 2021, but we've seen similar disparities since then. And this was originally based on the Mary Bassett's seminal paper on PLOS medicine. But Black, Hispanic, and Native American people have been 4 to 14 times more likely than white people and Asian people to die of COVID-19. So we started statepolicies.com, the state COVID-19 US state policy database, to track COVID prevention policies and policies to reduce economic hardship in real time, knowing that these policies would be very important to learn from and to help inform a strong response. So we started out tracking the first physical distancing policies and policies like eviction freezes and unemployment insurance, and grew the database into more than 200 variables that are contained in these different tables. This is our data library where I spend all of my time, and which may be where you would be most interested in as well. But you can download the tables of vaccine distribution phrases, or we also had like vote by mail, face mask mandates. You can download the dates of these policy changes today, and we tried to make it very easy to link to your data. We included the FIPS codes and the state abbreviations and the state names, so that whatever format your data are in, it can be easily linked, and we can study how outcomes changed before and after policy changes. And this is just an example of what the data look like, how the table is set up, and the kinds of dates that you'll see. But this was particularly important to have information on the dates so that we could conduct like difference and differences analyses and event study analyses to really get a good sense of how policies changed health outcomes and economic outcomes. So I'll tell you 3 policy stories today, 2 studies that we conducted that were able to inform policies and are more of a success story, which is something we need right now, I think, where we can have policy analyses that inform policies that help improve population health and health equity. And then a story about what we can do better in our work in that domain and the need for more work in that domain. So the first study is on unemployment insurance expansion and food insufficiency. These are also each kind of different ways of working on policies. So this study was informed by our policy database, but we actually looked within individuals and how things changed within individuals when they were affected by a policy. The next study on eviction freezes is linking state level data, how state outcomes changed before and after a policy. And then the COVID work has really been about communicating the policy evidence that already existed and putting forth policy proposals. So food insufficiency rose quickly during the COVID-19 pandemic, with 50 million people losing work and that being concentrated among people in low-income households with low amounts of wealth to rely on. Throughout the pandemic, food insufficiency was higher in households with children. And of course, that can have lifelong implications for children's health and well-being and educational attainment and human capital. Unfortunately, in the United States, unemployment insurance is characterized by having low coverage. Just 25% of people who lose work receive unemployment insurance. They receive low amounts of unemployment insurance relative to European countries, and for a short duration of just 12 weeks in some states, up to 26 weeks. And federalized administration, so it's administered state to state. And you may remember from a couple of years ago the pictures of lines of people waiting to go get their administrative paperwork processed. And it turns out that the history of unemployment insurance being designed this way is actually racist by design. That in order to get unemployment insurance passed, and the system that we do have in place implemented, there were exclusions. So people who worked in informal sectors, people who did part-time work, people who are independent contractors were excluded from unemployment insurance. And that was explicitly to get policymakers who were racist to support the policy. And this is something we saw again and again. This was one lesson that we learned from tracking several policies, is that exclusions often exclude the people who most need the policies. The people who have the lowest wealth are most vulnerable to food and housing insecurity. They don't have unemployment insurance. They also often don't have minimum wage even. They don't have paid sick leave. They don't have paid parental leave. They don't have health insurance. And so we systematically exclude the people who most need to benefit from policies from those very policies. And so when we think about something like the child tax credit or food stamps and like work requirements, like those again are ways of excluding some people who most need the benefits. The unemployment insurance system was already weak. And then after the Great Recession, several states made unemployment insurance even less generous, so that it was really didn't cover a large portion of the population. And so some of this work is important to inform, like, how might there be reform of the unemployment insurance system down the line for people who experience unemployment at any point, right? Because we have these comprehensive reforms that happened during COVID. So learning from them is very important. So the comprehensive reforms, the good news on policy. The CARES Act expanded unemployment insurance to more people. It covered independent contractors, covered part-time workers. It covered people who would have been excluded for earning too little, which was a reason you could be excluded from unemployment insurance. And it gave people a $600 a week supplement to the amount of unemployment insurance that they were receiving. But then it ended. So we studied what happened during this initial period before the additional stimulus bills. So we aimed to evaluate the relationship between unemployment insurance and food insecurity among people who lost work during the pandemic, and evaluate the relationship between the amount of unemployment insurance and food insecurity. So we used Understanding America study data, which are a fantastic resource for anyone looking to study several important topics during the COVID-19 pandemic. It follows individuals, about 8,500 individuals since the start of the pandemic, and with some data collected prior to the pandemic, over 4 years prior to the pandemic. So you can understand people's circumstances before the pandemic and during it. We limited our criteria to people earning less than $75,000 in the past 12 months, who reported being employed at the start of the pandemic in February 2020, and who lost employment at any point during the study period, and who participated in at least 2 waves. And this part of the design was actually hard because we didn't want a changing denominator. We didn't want people to enter the denominator as they lost work. We wanted to be able to compare the same set of people continuously throughout the study period. So these are how we developed these criteria. And we did this study from April 1st to November 11th of 2020. Our exposures were receiving unemployment insurance benefits in the past 14 days, and receipt of unemployment insurance during the period when the CARES Act supplement was in place, the $600 a week supplement. And then we also looked at the amount of unemployment insurance in $300 increments. Our outcomes were food insufficiency, worrying about running out of food and because of a lack of money or other resources, and eating less. This is really kind of a sensitivity analysis just to look at 2 different outcomes. In the past 7 days, did you eat less than you thought you should because of a lack of money or other resources? And here we used a linear model because of the individual fixed effects that we had. We looked at food insufficiency as the outcome and unemployment insurance as the exposure. For the event studies, we looked at waves relative to when someone received unemployment insurance. So we thought of that as relatively random because there was so much difficulty in administering unemployment insurance that when people received it really varied over time and could depend on their local administrative processes. So it wasn't like everybody who lost work in March 2020 was receiving it immediately. Sometimes there were months-long delays. And then we looked at, we adjusted for stimulus payments, for SNAP benefits, for whether people had a job, because like I said, like we compared people who ever lost work. So they might have then gotten a new job during the study period. And then we had individual fixed effects, so that we were adjusting for any time invariant individual characteristics like race or ethnicity or age. And then we had survey wave fixed effects to adjust for secular trends. We also ran several sensitivity analyses where we included survey weights, where we restricted participants who contributed to the UAS each month, and we restricted to the period when participants were unemployed, and running logistic as well as linear regression analyses. So we found that, sorry, I can't totally see my table here. Okay, so we found that about half of participants lost work, and that people who were Black and Hispanic and Asian were more likely to have lost work. People who were female were more likely to have lost work. Lowest income people lost work the most, as did people who were the youngest and oldest. And these are our main results in the event study analysis. So we found that there were relatively comparable trends in food insufficiency, like no trend line here, before people lost or before people received unemployment insurance. And then once people received unemployment insurance, there was this decline in food insufficiency that was 4.3 percentage points overall, or a 35% relative decline in food insufficiency. And you can see that the decline was largest in this earlier period, and this is when the supplement was in place. We found the same thing with eating less due to financial constraints, that there was a 48% relative decline after people received unemployment insurance. And then looking at when the $600 federal supplement was in place, we found that the decline in food insufficiency was much larger during that period than during the period without that supplement in place. And when we looked by amount of unemployment insurance that people received, we found that there was a big difference in reduced food insufficiency for people who were receiving $900 a week or more, relative to people who were receiving smaller amounts. So like, for instance, Mississippi only gives $235 a week in unemployment insurance. So that wasn't enough to help people avoid food insufficiency. So our main conclusions were that unemployment insurance was associated with a 35% reduction in reporting any food insufficiency and a 48% decline in eating less, and that the $600 a week care supplement nearly doubled the reduction in food insufficiency. And at the time we said, policies makers may wish to continue expansion of unemployment insurance, and that this might be something that they would consider doing longer term in future disasters, or in non-disaster periods when everybody who experiences unemployment would benefit from these policies. And that this was a success story during the pandemic, in the sense that it helped the study and others helped inform the second and third stimulus bills. I also found the preprints were really important. We put everything out as a preprint during the pandemic, didn't find that it affected our publishing, but it was able to help inform policies. The preprint was published before the second stimulus bill, and then the paper was published before the third stimulus bill. So we were able to inform both discussions because of this work. And so there was an instance where rapid response work was important. In terms of unfinished business, and where we still have a lot of room to improve, is to help people who experience unemployment at any time. I think this is a lot of what we can learn from the pandemic, is that people who experience a sudden shock of any kind, unemployment or illness like cancer or missed work because of the flu, or any number of things, they are experiencing food insufficiency every day, right? That we don't see in data when we don't have a pandemic to collect food insufficiency data every 2 weeks. They're experiencing risk of eviction and homelessness. That makes it much harder for them to have stable housing for a long time to come. day to day if they experience a shock like this when we don't see it in the data. So when we have these unusual data, it's very important to learn from them. And this is what we can do now is recognize that we have an unemployment insurance system that is particularly weak, that is covers a particularly low proportion of people, and inform, and that is and that does have a racist legacy, and that we can improve that to improve population health and health equity, and economic stability. Are there any questions about that study before I go to the next study? All right,
What's
great.
your limitation and the future plan to expand this work?
Yeah, that's a great question. So, limitations and future directions. So the limitations, I think these data are nationally representative, but it's just one data set, and I think that some of these internet surveys, the Understanding America study and the Household Pulse, it's much harder to include people who don't have internet or phones, and they do make an effort to do that with Understanding America, but I don't think the data are 100% representative of the population. So it probably actually leaves out some of the people who are most likely to experience food insufficiency. And then I think understanding heterogeneity and unemployment insurance by race and ethnicity, like these would be important priorities, in understanding how unemployment insurance receipt affects people with, for instance, like different amounts of wealth, and how those exclusions interact with with wealth disparities that were also shaped by policies, how they contribute to them, to making them worse. I think that's important. And I think more work focused explicitly on exclusions. Like we tend to be drawn to what we can study and looking at who does receive a program and how different people who do receive a program benefit from it. But I think it's actually like a whole research agenda should be built around who doesn't receive programs, who's not receiving paid leave, even when states mandate it, who's not receiving unemployment insurance, even when states mandate it. And are they the same people not receiving this, several programs? And how does that end up affecting food insufficiency, housing insecurity, and poverty, and in ways that are harmful to the whole of society, and especially to those who experience them?
Julia, just one quick follow-up. According to the Understanding America website, only 10% of the people that they approached actually completed the surveys. That means 90% of the people they tried to recruit didn't participate. Those of us that do surveys and collect our own data, the New England Journal and JAMA won't publish our work unless we get a 60% response rate, because they're afraid that the people who don't participate are different. And I understand there are disciplinary differences. Economists use data sets, for example, that those of us that do survey work wouldn't use because of that. Is there any mechanism by which you can compare the estimates you found in this to basically probability-based sampling with high response rates to know what you're seeing and whether it's different or not?
Yeah, this is a challenge throughout the COVID pandemic because some of the best data sources have very low response rates. This is similar with the Household Pulse survey, which is also an internet survey and has sub 10% response rate. I thought it was a little bit higher for Understanding America at the time when we did the study. But even prior to COVID, I was working with the behavioral risk factor surveillance survey data, and that's like a 60% response rate. So there are always a lot of people that we're missing. I think that we can use different data sets to learn different things. In this instance, we are able to follow individuals and be able to see something about the trends over time. They did also have high response rates within the panel. So the people who were part of the panel did have high response rates. And so we were able to at least follow the same people over time without a lot of people dropping out of the sample entirely. With the household pulse survey, it's a repeated cross-sectional data set, and we're able to see that relatively similar people from the same state populations over time, but knowing that some proportion of people are omitted, and that people who are higher education, higher income are always participating in these studies more. So I think it's learning what we can from these data sets that have that major limitation. And then it's also using surveys with higher response rates. I haven't actually looked into the BRFSS during the pandemic to know their response rates, but I would also expect that to differ from what it looked like prior years, whether that's because of, in a good way, like that more people respond, but I just would expect it to be systematically different. And so, I think we have to learn as much as we can from the data sets that have these limitations, but also that have useful information, large sample sizes, and make an effort to be nationally representative and have a sample that is from all 50 states and that includes people of different income levels and races and ethnicities. I'm curious if you have any other thoughts beyond that or suggestions of other surveys that are better. We're also doing some work with the current population survey. So that's another one where we can learn, but different data sets have different information and allow us to ask different questions. I see there's a chat. Okay, great. Thank you. Yeah, so I hope that's helpful. And I'll look up exactly what the response rate was, but I thought it was a little bit higher than that when we first started out. All right, so let's see, our next study. Our next study was on eviction freezes and COVID-19 cases and deaths. And this work was led by Kate Leifheit at UCLA. So this study was designed with US states that ever instituted an eviction moratorium. And states entered the study when the moratorium was first effective, and they exited the study either when the CDC implemented its nationwide moratorium in September 4th, 2020, or when there was a second moratorium. It's an event study analysis again, so looking at time to exposure since the moratorium was lifted. The outcomes were confirmed cases and deaths, and the covariates were testing rates and public health interventions, stay-at-home orders, school closures, and mask mandates. And we included fixed effects for time and for state again. So these are this is a map of the states that had eviction moratoriums in place in purple, and the dark purple is if they ever lifted the moratorium, and then the light purple is if their moratorium remained in place throughout. This is a timeline of when states implemented eviction moratoriums, again in the light purple, and when they ended the moratoriums in dark purple. And here what we looked at was the spread of COVID-19, incidence rate ratios after states lifted their moratoriums. And we found that it was 2.1 times higher incidence after states lifted their moratoriums. And we found that deaths were 5.4 times higher after states lifted their moratoriums. And we thought that this could be because people who had higher risk health conditions and were at higher risk of severe COVID may have been most affected by moratoriums being lifted. And we estimated that there would have been 433,700 excess cases associated with lifting the moratoriums and 10,700 excess deaths. And this study was also a success in that it was able to inform the CDC eviction moratorium and help support it through several legal challenges until it was ultimately lifted in the fall of 2021. And I think, again, thinking about the policy implications of and what we learned from COVID, I think we came to understand more about evictions because of COVID and just how profoundly they affect people. And if we look at the lifetime risk of ever experiencing homelessness, there are huge racial disparities in that lifetime risk. And that's partly because of those wealth disparities that I showed at the beginning. And that's partly because of our policy decisions that we do have evictions. And so during the COVID pandemic, we showed that we could freeze evictions. We could help people stay in their homes, and that made a very big difference for themselves and their families. I think just like we learned from mixed methods research, I learned a lot from journalism during the pandemic that really covered people who were experiencing these policies firsthand. So this is Yolanda Jackson, who was covered by The Daily. And she described that she was out looking for work one day and the eviction warrant was served to her son. And so then when her son was doing Zoom school and trying to learn in his Zoom classroom, and the mailman knocked on the door to deliver something, her son had a breakdown because he was so worried that he was getting kicked out of his home forever in that moment. So he couldn't focus on his schooling because he was so concerned about eviction. And because they wouldn't have had anywhere to go, it was a really destabilizing situation. Ultimately, through a combination of the policies that the eviction moratorium that was put in place and that helped her stay in her home, and then also a GoFundMe because she was featured on The Daily, her family was able to stay in her home. She described on her GoFundMe page just how she and her family were able to enjoy life and play a game of Scrabble and just relax with each other for the first time in a long time. And I think learning how profoundly food and housing insecurity affects people, and that we do have policies that can help people avoid these situations, and that can counter the legacy of structural racism and modern day policies that are structurally racist, like unemployment insurance, can help us think about how do we think about these policies, and how do we inform a stronger policy response in the future that helps people stay in their homes and keep food on the table. And then just to talk about a third topic about COVID prevention policies. So we actually ran toward the economic policies in our work because we saw other people running toward our COVID prevention data. So I contributed to some studies looking at physical distancing and ability to do that by income, but we actually really were focused on the economic policies as just part of informing rapid response research. Other people were doing really good work on the COVID prevention side. And what we learned that was especially important was that mask mandates were associated with reduced spread of COVID. And so here, these are two event study analyses, the gold standard approach for policy analysis, looking at COVID-19 case growth before and after states passed mask policies relative to over time and comparison groups. And what we saw was that there was reduced case growth and that grew over time because the cases prevented further cases downstream, whole chains of transmission. This was important for just thinking about the big picture realm of COVID prevention policy options. And we started to describe it this way. What's nice is actually this list has grown over time. Maybe y'all help grow too. But once we learned about COVID and once we had the development of vaccines, we had a lot of options for reducing the spread of COVID that were not lockdowns, that were not school closures, that were about masks, about ventilation, about test to stay, about mask policies during surges. And then, this last policy option is not having any policy, having short and long-term illness and death, lower quality of life, missed work in school, labor force supply and inflation impacts. And that's the world that we're in right now. And we're in with Omicron BA1. And how did we end up there? I think as we were learning about how to prevent COVID-19, there were also interests that were getting involved in the space. There was a really big effort to not have workplace protections for workers. There was a lot of lobbying that happened to prevent the original OSHA, excuse me, OSHA emergency temporary standard, which would have required masks in workplaces. There were groups funding, compiling op-eds against mask mandates and sending them to school boards, and encouraging people to go to school board meetings and protest masks and to turn them into a hot button issue. And there were efforts to roll back public health powers and to prompt sort of a backlash to public health powers more broadly. And so this context in which policies are made and implemented affected the whole country. And at the time when the CDC made the federal decision to recommend that vaccinated people no longer needed to wear masks, which was effectively ending recommendations for mask mandates in the country, less than half of people were vaccinated. There was still a lot of work needed to be done to get more people vaccinated, and especially to address vaccine disparities. At the time, there were very large racial and ethnic disparities in vaccination and income disparities. So in this domain, we really just started communicating about the policy evidence that existed, and about what we saw that was happening. And this is still an ongoing project because there are corporate interests and other interests that are communicating misinformation or disinformation about public health prevention policies. And so what we seek to do is to be first. A lot of, I feel so privileged to have the opportunity to connect with journalists and talk about COVID. And half the time what I'm saying is, if someone is coughing, you want them to be wearing a mask, right? It's just putting out accurate information. Like COVID spreads through the air, masks reduce spread, and mask policies reduce it more. So being first, being right, and promoting action. And, this is something I think is important for all of us in public health to do. If there are interests communicating against public health, then, and if we don't see that the federal government is communicating about the pandemic and about public health in as strong a way as it can, then we can contribute. We're part of the field of public health, and we can speak up and say, well, this is what's happening. This is what would help. I saw today that the White House had tried to set a potential acceptable number of deaths from COVID of 200 a day. And I calculated that there had been 1,118 deaths a day for the last 365 days. So in that sense, I think there's a lot of room for us to do better. We also had 63% more Omicron deaths in the United States relative to any other high income country. And we had the same thing during Delta, and they're all characterized by very large disparities. And they weren't inevitable, they were policy decisions. But we can speak up for policy decisions that will help improve population health and health equity. That's a lot of what we tried to do. We wrote a lot of op-eds. I did a lot of media interviews, just trying to let people know about vaccine disparities, about the importance of vaccinating essential workers. Sorry, my dog feels very passionate about this, just downstairs barking. And then we tried to communicate when there were surges happening, that it was, that we were in trouble, that we were vulnerable to a lot of deaths, and that we could have policies that would turn on and off. Our mask mandates, one of our most effective strategies for reducing the harms of COVID and COVID transmission. We're so grateful to have vaccines that reduce severe disease, but if we have 10 times more COVID, then even the vaccinated people are more likely to be harmed by it, because the vaccines are not perfect. And of course, we have a lot of work to do still to vaccinate more people and to boost more people. And so again, we've now surpassed 1 million deaths, and this, we could have been hundreds of thousands less with different policy decisions, with different kinds of communications about how the pandemic continued to be harmful, and about how important it was for people to get vaccinated and boosted, and efforts to deliver that equitably. We've seen these huge income disparities in vaccination that we've been communicating about for over a year, that, since the mask policy decision was first made. And this is what we see in the data that are ongoing. So again, this is household pulse survey data, suffers from the same low response rate, but again, like has information in it that can be helpful for understanding trends and helpful for understanding different subpopulations. We don't have COVID case and death data by income. But when we look at missed work, which is the question that's in the household pulse survey data, and we look at that by income, we actually see that people who are in low income households have been 10 times more likely to report missing work on average than people in the highest income households. So people in low income households are missing work first and most in every surge. And it's not been protective that they missed work first, that they missed work most in the earlier surges. It's happening again and again. And so this is sort of the longer term future of COVID. What does this mean? What does this mean for people in low income households? And how do we help reduce that toll and support people when they do miss work? We see similar disparities by race and ethnicity. These are the only races and ethnicities that are reported by the household pulse survey. And here we see Black and Hispanic people are about twice as likely, more than twice as likely to report missing work as people who are white and Asian. And this one I think is important for us. This is education level. So we can find ourselves on this graph, right? Like we are people who have graduate school degrees. And again, we're 10 times less likely to have missed work relative to people who are in the lowest education levels. And so I think this is important because so much of the discourse about COVID, the op-eds about COVID have been written from the standpoint of like, what is the rational individual choice for someone who's in this purple group, right? And that's very different from what are the policy trade-offs for the population. And that's very different from what do we do to help support the people who have been most affected, the people who are most vulnerable? What do we do to prevent this for that population? And that looks like workplace safety standards. That looks like mask mandates during surges. That looks like paid leave. That looks like child tax credit for when people are missing work. And so that's the urgent work that we're doing now, and that we need more urgent work to inform while there is still potentially a policy window to inform that likely before November. And I think in November, we anticipate turning toward the longer term and probably more state and local level work to how can we support people? How can we reduce disruption to health and the economy and help people live well as possible with this in our midst. So we'll continue to be to do a lot of public health communication and try to let people know what the facts are and anchor our policy decisions and our discussions in the facts. And we hope to help inform kind of this longer term policy discourse about, what do we learn from what went well and what didn't go well? And how do we establish policies that help people in this longer term recovery? So we hope that the state policies database will be helpful for that, for learning about how people are doing with different paid leave policies right now. There's a need for more work on children in particular, because we do see that child poverty and food insufficiency are rising again. We are still not in the clear and still in a very challenging period in our history. And in the past 5 months, child food insufficiency has increased by 20%, and looks that it's set to continue on that trend as there's high inflation, as the child tax credit expansion has expired. So hopefully these data are useful for helping to inform that. Hopefully these policy studies are useful for sharing how we think about policy analyses and informing better. And, I think there's still a lot of need for more work on the COVID prevention policies too, on what happened with mask mandates during Delta and Omicron. We still need a lot more of this work and a lot more work to center equity and help ensure that we are reaching people with effective vaccine campaigns and booster campaigns, that we do have in place a strategy for the next time there's an Omicron BA.1 type surge, or for repeated surges like we're seeing now, BA.2, 3, and 4, that can have a very high cumulative toll, even if each of the surges doesn't appear to be as large as the BA.1 surge. So I hope this is helpful for thinking about policies and informing future work. And I look forward to questions and discourse and maybe learning a bit about what you all are doing on the COVID and economic hardship front.
Thanks so much, Julia, for that great presentation. Are there any questions for Dr. Raifman? I'll start if there isn't one yet. I know you mentioned that there are still kind of groups that are getting excluded from a lot of the data. What data gaps do you see that are still existing right now that we could probably work better on since the pandemic's still ongoing?
Yeah, I'm really glad you asked that question. And I think that's something we could do better as a field, is start to put together the list of like what we need and research priorities. And one of those is long COVID. Another is COVID reinfections. Good news on that front, though, that the household pulse survey, like the June survey, will actually include those questions for the first time. And by the way, for all of you researchers, I don't know if this made a difference or not, but twice now, I and someone else participated in the survey, and we asked for questions to be added, and they were added. And so I don't know if that was why, or if they were already thinking about that, because they are important topics. But if you participate in the household pulse survey, then definitely ask for questions to be added. But I'm really happy that those are going to be included in those data, because I think we have a lot to learn about what people are experiencing. I think understanding the average duration of illness and effect on people's well-being is important. I surveyed my Twitter followers, which is, if you could have a bad sample, like a worse sample, like that's completely unrepresentative. But I was surprised that by just how many, like it was something like 40% of people who had COVID had experienced, had not recovered fully by 8 weeks. And that was longer than I expected. And I think that's important for us to understand as we're thinking about policy trade-offs. And thinking about, how often do we want to have to deal with mask mandates? Is it better to deal with mask mandates than it is to deal with, more than 8 weeks of illness, like a fair amount, a good chance of having more than 8 weeks of illness, like potentially. And I think it partly depends like how debilitating that illness is. I think there's a lot of work to do to describe kind of different policy trade-offs and like living well with COVID. Part of the urgency of normal kind of idea, like one of the shortcomings of it is that we actually haven't done a lot of things that we could do, right? Like move large events like the gridiron dinner outside, or ask businesses to pay more if they're going to hold an indoor event without any mitigation measures, right? And then if it costs them less to hold the event with some mitigation measures, then that's a good incentive to do that. So I think thinking about policy trade-offs and getting more people involved in that discussion, right? Like most people kind of think of one person as leading that discussion, and we need more people to weigh in on how we think about it from a population health and equity perspective. And I think there's never been a more important time to like share your voice, write op-eds, and share what you're seeing in your data to help center the conversation. And that has been, we've learned some of that for other things. So like when the recent shooting happened, we could immediately share data that showed some of the research on guns and the relationship between guns and gun deaths, right? And that can anchor the conversation in a way that's productive than if you just have different ideas that aren't anchored in facts. So I think that's a lot of our role in the disinformation age, is to help try to get out the information. The whole Be First idea is actually to guard against disinformation. It's just that in the social media age, you have disinformation coming in a lot more frequently and with much more of a platform. Is there another question? Yeah, great.
I'll ask one. So Julia, we've talked a lot sort of about the failures of communication during the pandemic. And I was just wondering, I totally agree with you that we sort of have to get out of our little ivory towers in our offices and start, talking more to the public to fight some of the disinformation. But none of us are really trained in doing that. So, I was just wondering if you sort of had thoughts about, boning up on our communication skills for doing this so we don't actually, do it in a way that ends up being counterproductive.
Yeah, that's a really good point. And I think it suggests that we should have a training on it, right? So that everybody can engage on these things. And that we do want to try to be as accurate as possible, as simple as possible, right? But we could be well-meaning and we could confuse people by just doing too elaborate a description. A lot of what I do is just describing things in like the most simple terms, like it threads through the air. And trying to do it to describe it in ways that people can relate to. We need layered mitigation in surges, like these very simple facts. I'm trying to think about the big picture and what are the most important things for people to know. It has been much more harmful to kids than the flu. It also harms their parents, which is harmful to the kids, like these kinds of sort of basic facts. I think the strategies that I follow are that kind of be first, be right, and to just focus on, not getting too bogged down in the details, but just having those main facts at hand and what their implications are. And I think keeping big picture in mind is a lot of what the policy work is about too, right? Like a lot of the op-eds that are against public health mitigation measures, like they deal in partial truth, right? Like the risk in 5 to 11-year-olds is small. Like the risk to 5 to 11-year-olds is the lowest of all age groups, but like there are other populations in school and they have parents and siblings and grandparents, right? Like, and teachers. And so a lot of it is just kind of pulling out to the big picture to be like, what is the population harm? What is it that we can do to prevent it? What do we know? It's also so easy to get bogged down in policy debates, right? Like, how much do you believe those event studies? But I think a lot of it too is coming back to the logic, right? Like masks reduce spread. Masks on the person with COVID are most important. The way you achieve a mask on the person with COVID is to have a mask mandate. So I don't know how helpful that is. It makes me feel like we should have a training from somebody who is an expert, so to empower people to speak up and to connect more people with journalists. Because I think a lot of what's happened too, and part of the reason I've ended up doing a lot of press is because people come to the same people over and over again, but that leaves a lot of room for, one person to shape the debate in a way that may not be as helpful or not as equity oriented. And so I think that is something important for us in public health. I see another question.
So hi, Julia. Thank you for the presentation. So this is hardly the first time that misinformation has clouded a public health issue, and it's going to continue and it's going to be worse. So give us your reflections about sort of what you think we should be doing around training and how we respond. I mean, in a way, it's hard to get a grant to go combat misinformation. So this sort of becomes sort of an add-on to the day job. And sometimes they're a costly one in terms of emotion and, even potentially threats. So give us your reflections on what we should be doing as a profession and as schools.
Yeah, thank you. I think it's an important moment for us to think about, who we are and what we want our profession to be and why we're here. And so, yeah, part of that is, are we standing for public health? Are we helping, are we going beyond writing our papers? Why are we involved in public health? And if it's to improve public health policies and programs and measures, then part of it is going to be doing some of that speaking. And is that a part of the service that we do to the field and to the population at a time that remains, to me, it remains an emergency. We're still working at an emergency pace. In fact, more so because we don't have the policies that we need in place. And so doing whatever we can to inform them being better is important for reducing more deaths and disease and economic hardship. So yeah, I think I think it is something that's important for us to not just focus on our career. So it can be part of career building to be engaging with journalists, but to also think about our shared mission to help improve the public health and equity.
Thank you.
Oh, hey, Julia, I have a question. At the APHA last year, there's a hot discussion about the combine those Asian American Pacific Islander together. The COVID deaths among Pacific Islanders quite high compared to Asian Americans. So you're working on this in the front line. So what's your impression of those getting those measures from those marginalized community in your work?
Yeah, thank you for that question. I think that's a very important topic. And I actually, I think, but before the pandemic, I was doing a lot of work on LGBT rights and health disparities, and seeing if you don't have the data, then you can't study how policies are affecting people. And that's the same thing we're seeing here, right? Like, I can't look at food insufficiency among Native American people in the household pulse survey data or among Hispanic, Asian Pacific Islanders because they don't have the breakdown, right? And so we can't actually highlight that those populations probably need even more investments than the populations that are captured in the data. So I think that is very important data for us to have. And it's still, Dr. Kendi wrote about this 2 years ago now, more than 2 years ago, about how we didn't have the full breakdown of COVID by race and ethnicity, and we still don't. And it still means that it's very hard to conduct analyses of, for instance, how do mask mandates affect racial disparities? Because we don't have reporting for half the population. And so the missing data, it's very hard to know what's in the missing data and how that affects our analyses. And the imputation with 50% missing, is just it's a lot to ask of the data and can skew the results. So I think it's very important to have data by race and ethnicity. And I think that would be that's my, my next question for a household pulse survey too, is like they actually collect some more data than they release. And so I think releasing those data would be important to be able to highlight those disparities and the need for supports.
Thank you. Thank you for the great talk and answer. Appreciate it.
Yeah, thank you.
And we're up at 1 o'clock. So I would just like to thank Dr. Raifman for joining us in that wonderful presentation. And if everybody can help me say thank you, and thank you to all the other speakers who've been part of this wonderful seminar series. And thank you again, Julia, for joining us today.
Yeah, thank you so much for having me. Thank you for your great questions. And I'm happy to stay on for one more question. I saw someone had their hand raised.
That'd be great. Thank you so much. Thanks, everybody.